Dr. Patino. I'm the CEO of the World Association of Gluteal Surgeons. It is a total pleasure to have you here. This organization was founded by Dr. Miami in 2019. We founded this organization because of the reported mortality of 1 in 3,000 by ASSERV. Among about 7 of us, some of them are here today, we determined that we didn't have any death, and there were about 10,000 cases among us. And so we figured that somehow this didn't add up. So this is what we want to convey to you guys, that we want to make sure that every surgeon does this safely. Without further delay, let's have our moderator and first speaker, Dr. Jugenberg. He comes from Canada. He was one of the founders of this organization, and we're very, very pleased to have him.
Right, so thank you very much. Good morning, everybody. I will be moderating the morning session today, and I will introduce our first speaker. I've known him all my life, great surgeon. He comes from Canada, from Toronto, Dr. Martin Jugenberg. I will be talking to you about my experience with body contouring procedures.
So while we wait, I'll give you a little bit of background to this presentation. I'm a cosmetic plastic surgeon in Toronto, in Canada, and I do a large volume of procedures. I am a more aggressive surgeon in Canada that is very conservative. In Canada, most plastic surgeons do very little, and I'm somewhat timid in doing large body contouring procedures, so I kind of stand out. And I had a patient who unfortunately suffered a pulmonary embolism after body contouring procedure. Had some symptoms, was sent her to the hospital, she was put on blood thinners, sent home, everything was fine. But in Ontario, whenever we have an adverse event, we have to report it to our college. So the college looked at my case, and a local plastic surgeon reviewed it and concluded that I was lacking judgment, I've done too much surgery, I was unsafe, I should not have done what I have done, and I was going to be investigated. So instead of leaving it to my lawyers to deal with the college, I took it on my own to do lit review, to find publications to support what I've done, and I've done chart review on my own patients to show them that what I do is safe. And so the inspiration for this presentation, that's where this came from. So the case I did was in Ogmasto, Lipo 360, and an extend tummy tuck on a patient with a BMI, I believe her BMI was about 27. The plastic surgeon who reviewed my case felt I've done too much liposuction, my 4-hour procedure was too long of a procedure, and I shouldn't have combined liposuction with a tummy tuck and all the other things. And I should have kept her in a hospital. So I went ahead, did lit review to support myself, which I submitted to the college, and I've done chart review, and that's what I'd like to talk to you about today. The title of this presentation is VTE and Other Complications in Liposuctions and Other Body Contouring Procedures which Involve Liposuction. So VTE is a serious potential life-threatening complication that we deal with, aside from fat embolism in BBL. It's probably the most serious thing we deal with. And there are various risk factors. There are known to be risk factors for VTE formation, but despite our best efforts, these things still keep happening. The current recommendations for VTE prophylaxis vary. The data that's out there is for inpatients only. And the data really shows that only those with Caprini scores over 7 benefit from chemoprophylaxis. And most VTE in plastic surgery patients occur in low Caprini scores simply because the patients we deal with have typically low Caprini scores. There's a screenshot of a graph from one of the papers by Dr. Panucci. He's done a lot of research on this, done a lot of publications, which clearly shows that use of low molecular heparin, such as enoxaparin, doesn't become effective until Caprini 7 or 8. The understanding of VTE and understanding the significance of it and prevention has been widespread, and this is a chart showing surveys of plastic surgeons from 2001 to 2023, showing increase in percentage of survey respondents who are doing some sort of prophylaxis for VTE. A survey by Amy et al. From 2020 looked at ASPS members. 74% of users or respondents were using Caprini scores, and mechanical prophylaxis was used by up to 54% of surgeons, mostly in cases that were 3 hours or longer. A more recent study by Stein in 2023 showed that it has increased to 95% of surgeons using mechanical prophylaxis, 21% using chemoprophylaxis. I've done my own informal survey, spoken to my colleagues from across the world, and I found that there is no set protocol that everybody follows. There's a variability on how people do things, what kind of drugs they use, when they use them, so there was really no set protocol on what to do for proper VTE prophylaxis. Despite everything that we do, despite all the publications, despite years of research into this, PEs and DVTs still take place. It's not difficult to look up literature and find some papers that looked at 1,500, 1,600 patients, 24 patients, which is 1.5%, still sustained a VTE. 19 of the 24 patients were on chemoprophylaxis. Paper by Sozer in 2018 reported one fatal PE in a patient who had no risk factors and was on chemoprophylaxis. So what do we do in our clinic? In our clinic, I try to avoid DVTs and PEs, so all patients are being assessed for the risk. Anybody with a coagulation disorder is not accepted. We don't operate on such patients. For our prophylaxis, any patient who is being operated on for more than 45 minutes is given SCDs while in the OR. In recovery, the patients are kept warm, they're encouraged to move their legs, and upon discharge from our facility, we encourage strict mobilization. We did not use chemoprophylaxis for any of our patients. So how safe are our surgeries? So this was in response to the complaint against me. I've looked at liposuction volume, surgical time, BMI, Caprini scores, procedure types, and whether or not this was a single procedure or combined procedure, and how it affected specific risks such as VTE, seroma, infection, wound healing, or something else. What we've done is a chart review. Now, I've started using NextTech medical record system in 2014, so that's why I went back to January 15, 2014. Up until August 16 is when I received the complaint from the college, so that's my timeline. The inclusion criteria for my review: any body contouring procedure involving liposuction alone or in combination with another procedure. The exclusion was if this was an incomplete chart or if this was not a body contouring procedure. All patients had a minimum of 3-month follow-up. What we found is 2,474 procedures, 1920 were single procedures, and 554 procedures were combined, where there was a main procedure and some sort of an add-on. And you can see in the table the breakdown. Most of these procedures were tummy tucks. Second most common was BBL, and then liposuction. When I say liposuction, I mean liposuction was the primary procedure, maybe we did something small aside with it. Abdominoplasty means abdominoplasty was the main procedure, and naturally we would do some liposuction with it as well. So the liposuction would be a component of all those procedures. And when I say liposuction by itself, that means we did nothing but just liposuction. So the adverse events we looked at were either a VTE. Any VTE would be any patient who had radiologically confirmed thrombosis. Seroma was any seroma that was significant enough for aspiration or drain placement. Infection was an infection that was significant enough requiring IV antibiotics or surgical management. Wound healing was any wound healing that had distance of greater than 1 centimeter or skin necrosis. And there were others. So we had patients that had pain, two patients that required transfusion, and 1 patient that had an allergic reaction. We had no post-op hematomas, no mortality. So let's look at the results that we found. So first thing I looked at was the liposuction volume. So at first I split into small volume, large volume. So under 5 liters, over 5 liters, looking at the various factors. And I've highlighted in color the ones that seem to have stand out. So you can see seroma is clearly increased in liposuction over 5 liters. No other increases have been seen. When I break it down to a little more specific volumes, interestingly, most VTEs took place in cases that had liposuction less than 1 liter. There was one case in a high liposuction volume over 7,500 cc's. Seems to stick out, but because of the low number, it wasn't statistically significant. So the only statistical significance in this review was increase in seroma formation. Next, I looked at single versus combined procedures. It appears that multiple procedures increase risk of VTEs and increase risk of infection. The statistical significance is very, very small. In the table next to it, you can see the breakdown. So when it comes to VTEs, 15 of them took place in tummy tucks, of which 7 were tummy tuck by itself and 8 were a combined procedure. Interesting that was that 3 were in breast augmentation with tummy tuck. Now my breast augmentation takes only about 30 minutes or less. So what I found interesting is that the breast augmentation didn't really add extra time to the surgical procedure. I think would be significant, so it was interesting to see that. Next, I looked at procedure types. So I broke it down to different procedures: tummy tuck, arm lift, BBL body lift, brow line lift, liposuction, mini abdominoplasty or thigh lift. Abdominoplasty appears to be a risk factor for VTEs. That was an interesting observation. Seroma was the most common complication, and it happens in liposuction over 5 liters. So that's 3% versus 11%, under 5 versus over 5. I've grayed out the brow line simply because it's a very small sample. One seroma, one infection makes the percentages look out of proportion, but it's just a small sample. Next, I looked at surgical time. Broke it into different categories. Surgical time does not appear to increase risks unless you get to over 4 hours. And although there is a trend, statistically speaking, there is no statistically significant increase in the risk of VTEs in procedures over 4 hours. There's a risk increase in wound healing. Next, I looked at Caprini scores. So, as typical in most cosmetic plastic surgery procedures, most patients have a low Caprini score in the 2 to 4 range. Caprini score showed increasing risk, but again, not statistically significant. And finally, I looked at BMIs. BMI over 30 appears to increase risk of VTEs and wound healing, but is not statistically significant. So there is no statistical significance in BMI increases. As a little aside, I want to talk about large volume liposuction as well. So liposuction over 5 liters. Is it really dangerous? So ASPS guidelines from 2009 state that large volume liposuction is any liposuction over 5,000 cc's. It should be avoided, and if it is done, it should be done in a hospital setting with patient admitted for observation. And volume of liposuction is something that most plastic surgery societies around the world regulate. I know in Florida, I think you guys have a limit of, I think, 1 liter or 4. If anybody can help me, what's the limit in Florida?
It's if you're only doing lipo or lipo-fat transfers 4 liters. If you're combining it with the procedures of tummy tuck or breast procedures, then down to 1 liter.
1 liter, okay. And it varies. So I've asked my colleagues across US states, and it varies from something similar to 5 liters to some places that have no limits. A more recent guideline came from Britain, where Barbara's recommendation is that it's not really the volume, it's more the percentage of body weight that is the guideline. So they recommend 5 to 9% of body weight, which means for a 132 pound or 60 kilo patient, 4.8 liters, for a 100 kilo patient, up to 8 liters. So there's no clear evidence regarding volume of infiltration. And since 2009, when the original ASPS guidelines came out, liposuction changed tremendously. The amount of blood loss in liposuction has decreased from the early reports of up to 45%. We're now down to 1% or less than 1%. So blood loss is not such a big a problem. It will be more a question of fluid shifts. So what is the limit? What is the safety limit to large liposuction? More recent papers came out. There's 3 papers from the last few years, De La Cruz, Golpani, and Canapati, where their mean aspirate was over 7 liters with minimal complications. 0, 0.6, and 0.1.8% VTE rate. There's some older papers from 2015 to 1999 with 0 VTE incidences. So what do we do in our clinic? We treat them like regular liposuction patients. Our post-op care involves no hospital admission. We do leave an IV log in place, so when I see them the next morning, if I feel they're dehydrated or they need some IV bolus, we can give it to them. We encourage them to hydrate and ambulate. We warn them about the risks of dehydration, so we insist they must have a caregiver for 48 hours. There's risk of fainting. Looking at our charts, we've performed 383 cases of liposuction over 5 liters. These were treated as outpatient procedures, and seroma formation was the only risk. We had no hematomas, no mortalities, no hospital admissions. So to summarize, we looked at 2,474 patients. Our complication rate was 7.64%. with seroma being the most common complication. If I take seroma out, which is relatively a minor complication, the complication rate goes down to 3.4%. And interestingly, 15 out of 16 VTEs were abdominoplasty patients. 13 out of 16 were less than 5 liters. And what I found most interesting was that 11 out of 16 were less than 1 liter of liposuction, which makes you think, well, liposuction probably doesn't really have much of an impact on incidence of thrombosis. So in conclusion, abdominoplasty appears to be a risk factor for VTE formation. Overall risk of VTE in our studies was 0.65, 1.3 specific for abdominoplasties. Seroma was the most common complication, accounting for 4.2% of complications, and occurs primarily when liposuction is over 5 liters. Large volume liposuction appears to be safe. It can be done in outpatient settings and does not require hospital admission. And again, with large volume liposuction, seroma is the only risk that seems to have increased with increasing volume of lipo. So what have we done? We now provide chemoprophylaxis to all our abdominoplasty patients. If you remember, initially I mentioned none of our patients were getting chemoprophylaxis. Our protocol now is 5 days of enoxaparin, 5,000 units. First dose is given 4 hours after the procedure. If I have concerns about bleeding, I delay the first dose by 24 hours. SCDs were used to be used only in OR. We now make sure that patients have them in recovery until they're ambulating and leave the procedure, leave the facility. Now, literature is very definitive in that chemoprophylaxis has no impact on risk reduction in patients with capnia under 7. But this new protocol is in response to pressure from our regulatory body and to reduce medical legal risk. As I've spoken to my colleagues, a lot of my colleagues have started using chemoprophylaxis not because the evidence shows that it works, it is to cover yourself in case of a medical legal issue. So we are now giving prophylaxis to tummy tuck patients only, not all my body contouring patients. Only patients that get tummy tucks automatically get the protocol, and I hope to come back in a few years and let you know whether our VT incidence has changed as a result of the changes in this protocol. Thank you very much.